Welcome to this video on Microtia. Before we begin, consider the following questions. What is Microtia and why does it develop? How is Microtia graded? What are the key aspects to consider in the management of Microtia? How do you assess a patient's suitability for hearing reconstruction? And what are the cosmetic reconstructive options? Microtia describes an underdevelopment or absence of the external ear. It is typically unilateral, seen more on the right side, and is more common in males. In approximately 80% of cases, Microtia occurs as an isolated, non-syndromic condition. However, in around 20% of cases, Microtia is associated with a syndrome such as Treacher-Collins or Goldenhar syndrome. The external ear develops from 6 precursor structures, known as the hillocks of His, which arise from the first and second branchial arches. The first arch contributes the first 3 hillocks, and the second arch forms the final 3. These hillocks undergo a complex process of migration and fusion to form the pinna and its subunits. When this development is disrupted, the normal formation and positioning of the ear may be affected, resulting in Microtia. As the hillocks arise from the first 2 branchial arches, syndromes such as Treacher-Collins and Goldenhar, which primarily affect these branchial arches, commonly result in Microtia. In non-syndromic cases, the normal development may be disrupted either due to teratogen exposure or perhaps due to premature involution of the embryological stapedial artery, which normally supplies the developing structures. The exact mechanism, however, is not known. There are several grading systems that exist to categorize the severity of Microtia, with the Marks classification being one of the most widely used. In this classification, Grade 1 describes a smaller but otherwise morphologically normal external ear with all subunits present. In Grade 2, the pinna is smaller with partial absence of some of the auricular subunits. In Grade 3, the pinna is grossly abnormal with only a cartilaginous remnant and a fatty lobule remaining, and this is sometimes referred to as a peanut ear. And with Grade 4, there is complete anosia with no visible external ear remnant. Other systems include the weirder or Nikhita classifications. Microtia may also be associated with external auditory canal stenosis or atresia, and the middle ear structures may also be affected, as these are also derivatives of the first and second branchial arches, meaning that coexisting ossicular abnormalities are common. Microtia presents a number of challenges, including hearing loss, cosmetic deformity, and psychosocial impact on the patient, and therefore the management should occur in a multidisciplinary team setting, including ENT, audiology, plastic surgery, psychology, and speech and language therapy. Patients may have various degrees of hearing, from normal to a maximal conductive hearing loss, and early access to sound is critical for language development, and so a non-surgical bone conduction device, such as one mounted on a soft band, are often used from infancy. Definitive options include a surgically implanted bone conduction hearing aid, which can either be percutaneous or transcutaneous. In either case, the placement must account for future auricular reconstruction, with the implant placed more posteriorly to preserve the soft tissue envelope and its vascularity, which may be required for future cosmetic reconstruction. For patients with an open ear canal or a surgically repairable atresia, ossiculoplasty and atresia repair may be considered. The success of this depends upon the middle ear anatomy, and this is assessed with a preoperative CT scan and graded using the Jars-Dorfer system. This scoring system assigns 1 point to each important anatomical structure, such as the oval window, facial nerve position, presence and morphology of the ossicles, along with mastoid pneumatization. A maximum score of 10 is available, with the score greater than 8 indicating a good prognosis for hearing restoration. A score less than 6 suggests a likely poor outcome, in which case a bone conduction device is preferred. For the cosmetic impact of Microtia, a number of reconstructive options exist. This is a latter concern than hearing restoration, and is typically offered after the age of 8, by which time the contralateral pinna will have nearly reached its adult size. This ensures a more symmetrical final result. Prior to this age, adhesive auricular prostheses can be offered, which are non-surgical but provide an aesthetically acceptable solution. However, as the attachment is insecure, patients may opt for implanted prosthesis. This has the benefit of improved retention, but due to the soft tissue and vascular disruption involved, will preclude the option of a future surgical reconstruction. For surgical reconstruction, the two main options include autologous rib cartilage or an alloplastic implant, such as Medpor. Autologous cartilage is harvested from the rib and provides a durable and biologically accepted framework, but requires multiple surgeries, though has good long-term outcomes. By contrast, alloplastic materials allow a higher fidelity cosmetic outcome in a single stage, but has a higher rate of infection and subsequent extrusion. Given the visible nature of the deformity, children with microtia are at a greater risk of bullying and reduced self-esteem. Therefore, psychological counselling and support from family and school form an essential aspect of their care. I hope you found this video to be useful. I'd be grateful for your feedback in the comment section below, and let us know what you'd like us to cover next.